Bill for my minute. Bill, I get out. Right tomorrow.
Yeah.
Ben, can you confirm that you can hear us online? Testing 1, 2, 3.
Okay, will we be able to hear them online when they question?
Yes, Lynn talked earlier.
Oh,
Hear you.
oh, okay, great.
Yeah.
And is Steve Bedrick out there?
He sure is.
Okay, so we have the whole committee here. Are you ready to go?
Yes, I am.
Okay. Well, good. Why don't we go ahead and get started? Welcome, everyone. Actually, this is pretty good for a turnout lately in terms of our in-person conferences, but it's great to see everyone here, and I don't know how many people are online. Anyways, so today is a DMICE conference that we normally have on Thursdays over the lunch hour, but when people defend theses and dissertations, it's sometimes at a different time. And so today we have the thesis defense. I think this is the last of our graduates from this year who all have been fixtures in the department, and now a bunch of them are leaving, but that's supposed to be what happens. Anyways, the committee is all here. I welcome the committee. And the usual process for those who might not come to these on a regular basis is that the candidate doing their defense gives their presentation, the public asks questions, the public is dismissed, leaving behind the committee. They may ask further questions, and then the candidate is dismissed, and the committee decides if the student has successfully defended their thesis. So it gives me great pleasure today to introduce someone who has been one of the many fixtures around the department for quite some time. And Meenakshi Mishra is a fifth-year PhD student in the Health and Clinical Informatics major of the program. She's also been a National Library Medicine Fellow, which is how most of our PhD students are funded on our T15 training grant. Before starting the PhD program, she worked as a certified clinical research professional, managing and coordinating clinical trials in oncology and bone marrow transplant. I remember her telling me about that when she came for her interview. She has a master's degree in biotechnology from Banaras Hindu University in Varanasi, India. And she also received an MPH from the University of South Carolina before moving to the Northwest. Her interests involve using real-world data to generate high-quality evidence, secondary uses of electronic health record data for research and clinical decision support, improving informatics infrastructure for enabling the learning health system, and health data standards and interoperability. She's also a member of the N3C, the National COVID Cohort Collaborative Education and Training Working Group. And her current research involves data accessibility and quality issues focused on opioid use disorder risk assessment. I was delighted to hear when she told me this not too long ago that she actually will be moving on to a new role as a biomedical informatics research specialist with the Oxner Health System. I believe that's in New Orleans, right?
Yes.
Okay, that will be great. And she will hope to continue research collaborations with people here at OHSU and in the N3C community. So I will let Meena take it from here. And if there's any problems with the online, speak up and let us know.
Sure. Thank you, Bill, for a fine introduction, and thank you everybody for coming to this dissertation defense. So the topic for my research was defining gaps between information needs and readiness for assessing opioid use disorder risk in patients considered for long-term opioid treatment. This is a roadmap for this defense. Essentially, I will introduce you to the problem that I use to scope my research and introduce you to the research framework, basically aim 1, 2, and 3, methods and results for each of the aims, and share the conclusion, limitations, and future work. So here's the problem that I looked at when I started my research. Essentially, within a period of 10 years, 250,000 people died in the United States from overdose involving prescription opioids. Nearly 1 in 4 to 1 in 5 patients prescribed opioids misuse it, and 1 in 10 develop abuse. The economic burden from chronic pain and abuse and opioid use disorder runs into billions of dollars. To address this growing epidemic, there have been significant laws, policies, and guidelines that have been instantiated over the years. And since primary care providers take care of most of the chronic pain patients and account for almost half of prescription opioids, the role that it makes it worthwhile to look at what is the role of CDC guidelines in addressing this issue. Looking at the evidence for all other laws and regulations, I found there was a need for adequate data, that the data was not adequate to understand the exact impact of these policies at the patient level. And CDC guidelines provided a kind of a jump start for me to start investigating how much of a role this plays in addressing the opioid use disorder. This is essentially the CDC guideline, and I specifically looked at the arrangement of treatment for opioid use disorder, which is one of the recommendations by the CDC for the primary care providers who are prescribing opioids for chronic pain. However, in order to arrange treatment for opioid use disorder, the providers need to identify this in their patient population. Again, looking at other significant, more recent updates, there is a HEAL initiative that came out in 2018, which is helping end addiction long-term. And it essentially asks the scientific community to make efforts to understand pain and improve treatment for pain, and also to understand and prevent the opioid use disorder better. The national plan for addressing opioid misuse calls for the prescriber and medical community to make efforts to continue to evaluate and update prescriber guideline, including the CDC guideline for prescribing opioids for chronic pain, and standardize the use for anyone who prescribes the opioids. So there clearly is a role that medical community and scientific community plays in addressing this crisis. However, to address the triple aim of improving care, enabling research, and informing policies, we need a learning health system, a system where evidence flows to practice, practice flows to data, and data can create new evidence. This becomes really complex when we are dealing with a chronic pain and OUD, as they are both very complex conditions. Plus, there is an added layer of complexity when we run into stigmatized condition. Needing to build trust between them and the patients, providers often do not document, or they document variably in the EHR. And as a result, there's a need for an EHR data readiness framework that takes into account the real world challenges of caring for complex patients with stigmatized conditions. So I started looking at what are the different frameworks for understanding complex patients. And I found that stigma was not mentioned as one of the constructs. Basically, complex patients were described around medical complexity, socioeconomic factors, mental illness, or patient behaviors. But stigma was missing from from framework for describing complex patients. And understanding opioid use disorder a little bit better, it's a highly heterogeneous condition, which ranges from mild to severe, and it's diagnosed using the DSM-5 criteria, 2 out of 11, spanning over 4 different concepts of impaired control, social impairment, risky use, and pharmacological properties of tolerance and withdrawal. So fairly complex and fairly heterogeneous disorder. Initial review of literature for adherence to guidelines suggested that lack of time and training are significant barriers for primary care providers to care for patients on long-term opioid treatment. And educating providers in opioid risk assessment did not significantly change the rate of risk assessment in the actual practice, even though there was an increase in knowledge and willingness to apply risk assessment for initiating opioids. So clearly there was a gap. Also looking in the literature, I found that it takes on an average 17 years to just 14% of the published literature to be translated to practice. So all this kind of prompted me to define my research framework around these 3 aims. So the first aim was to increase understanding of barriers to risk assessment and use that for informing the information need and information readiness assessment, develop a methodology for those 2 aims, and then triangulate the finding and do an information gap analysis and provide a set of recommendations for future informatics projects. So looking at my aim 1, which was understanding tasks and barriers, so I knew that the gap existed, didn't know why. So I started my task. The first thing was to increase our understanding of risk assessment tasks per CDC guidelines and determine what the barriers are for translating the evidence to practice for OUD risk assessment and identify factors that may affect data in the EHR. Here's a bird's eye view of guideline concordant opioid prescribing for chronic pain in the primary care setting. Ideally, when a patient comes in the clinic, the provider is trying to determine risk versus benefit for putting a patient on a long-term opioid treatment. As a result, in the box up on the top, you see all the various information systems and tools that the provider needs to look at and use in order to make risk for their patients, determine risk for their patients. So there is a use of validated screening tools or questionnaires to determine if there is an opioid misuse or opioid use disorders happening. Also looking into the EMR for medical history for signs of opioid risk or aberrant drug-related behaviors. Looking at the urine drug screening results for any unexpected results. And also looking in the prescription drug monitoring program or PDMP for any signs of patients approaching 4 or more prescriber or multiple prescriber or multiple pharmacies that could indicate some misuse or abuse. So the aim 1, again, the method was to find from literature all the opioid risk factors and how they compare to what is in the guideline. In order to do so, I did a literature search, and the scope for the search was to include all literature that have opioid risk assessment elements for patients on long-term prescription opioids for chronic non-cancer pain. I included literature from PubMed and Scopus, and primarily the risk assessment elements that I touched upon in the prior slide, like screening tools, PDMP, aberrant drug-related behavior. I scanned all those to see if there were indication of barriers arising from the use of these different tools. I used 14 constructs from 3 frameworks for thematic extraction and synthesizing my findings. So the first one is the socio-technical model for health information technology by Sittig and Singh. This framework essentially looks at barriers to using any health information, health technology in the context of socio-technical, in the social technical context in the healthcare setting. So there are different elements in the healthcare that may affect or the adoption of a health technology intervention, like people, workflow, communication, user interface, software, hardware, internal policies, organizational policies, external rules, to name a few. So there are 8 total constructs from this framework. The second framework I use is the Katana framework, which is essentially a framework that was developed for understanding the barriers to physicians' adherence to practice guidelines. And it actually calls upon some behavioral constructs like knowledge, attitude, and behavior elements to adoption of best practice. And the third one was the Paris framework, which essentially defines successful implementation on the basis of strong evidence, or as a function of strong evidence, strong context, and strong facilitation. So clearly there was some overlap between all these 3 different frameworks, but they provided a good foundation for me to do thematic extraction and synthesize my finding. As you can see, the facilitation from the Paris framework up on the top actually does include some of the constructs from the socio-technical and health model for health information technology, like the clinical content, which is the EHR, or workflow and communication and things like that. And the context, if you can see that also overlaps between the 3 framework. The context in the Paris framework overlaps with the people and internal organization policies, and the people, construct in turn overlaps with the knowledge, attitude, and behavior. So quite a degree of overlap, but that was very good for me to ensure rigor in the thematic extraction. So here are the 12 themes that emerged from 51 studies for barriers to guideline, concord, and OUD risk assessment. And I'm not going to go over each one of them, but touch upon the important ones that actually prompted my further work. So essentially, there was the theme of variable documentation affecting data quality because of stigma associated with OUD addiction, leading to variable documentation and inconsistent documentation of opioid misuse and abuse in the EHR. There are also variation in the use and documentation of screening tools in the EHR, and aberrant drug-related behaviors used as an indicator of misuse are inconsistently and unsystematically documented. There are themes around, evidence and people also, and it appears that provider experience may be playing a role in the real-world decision-making, because most of the evidence in the clinical guidelines are supported by weak, most of the recommendations are supported by weak evidence. There is no widely used risk assessment tool accurately predicting or identifying misuse, and applying the DSM-5 criteria to patients on long-term opioid treatment has proven to be difficult. Also, level of risk is that patient provider determines for their patient is determined by the level of trust and history of knowing the patient. So clearly, there is a role for provider experience in making real-world decisions for their patient population. So the major takeaways from this, and for my next step, were again reiterating it, is the task of opioid use disorder risk assessment is fairly complex and data heavy. Providers often triangulate data from various sources in order to make decisions about the patient's OUD risk. In the absence of strong evidence for most recommendations, providers make decisions based on their experience. And associated stigma affect how PCPs document opioid misuse, abuse, and use disorder. And this was to maintain patient-provider trust primarily, and also to reduce harm because a patient may lose an insurance coverage for potentially beneficial treatment. So this is just a cartoon showing that the need, the provider's information needs may be due to some knowledge, in some cases knowledge gaps, but primarily may be due to the experience that they've gained from taking care of this patient population. So these were the questions from my aim 2 and 3. Which patient-specific information do primary care providers find useful in making decisions about their patient's OUD risk? And what does the availability and quality of useful OUD risk concepts or factors look like in the EHR? In order to address these two goals, I came up with this framework, like a generalized methodology to address these two goals. Essentially what I was trying to do is find the gaps between information needs for high opioid use disorder risk factors and the readiness of the EHR to address that need. And if you see, the information need part has two steps, identification and prioritization. And the information readiness has another two steps, operationalization and assessment. So let's go over what it means. So the methodology for AIM2, for the identification steps, I essentially looked into the literature and consulted primary care providers to identify all the opioid risk factors there are, and come up with carefully picked opioid risk factors for my Delphi survey in the next step. So what I wanted to do is look at and rank high need for the opioid risk factors in the real world clinical decision making, and in order to inform future informatics projects. So identification and prioritization involved literature review and modified Delphi survey to rank OUD risk factors. However, before I delve into the literature review aspect of it and how complex this step was, I needed a reality check. The reality check about what the opioid use disorder actually means, and the term, and how to apply that for literature, finding literature. Opioid use disorder is a fairly new. It actually was turned around somewhere around 2013, and it's another name for addiction. The addiction term has also evolved over time, and it includes dependence and abuse. People with addiction may also misuse opioids. Opioids misuse or abuse does not necessarily result in addiction, but opioids are highly addictive, and the risk increases with misuse and abuse. Also, in the context of the chronic pain population, it's important to remember that dependence does not necessarily imply use disorder for patients on long-term opioid treatment, as they develop dependence from extended use. So in this, with this knowledge, I conducted my literature search, and it was important to consult the providers to decide which opioid use risk factors, opioid use disorder risk factors, they would suggest to start my Delphi survey with. So here is all the literature review I did, essentially using the search terms for opioid-related adverse events, toxicity, and disorders to collect the wide range of literature. I ended up with 269 articles. After removing articles on dependence, overdose, or other toxicities, I was left with 25. And then I ended up adding more from a review of references of the primary literature. As a result, I ended up with 51 articles with factors related to misuse, abuse, addiction, opioid use disorder. And the reason I included misuse, abuse, addiction was I wanted to, because they can indicate increased risk for opioid use disorder or addiction. So here is like a word cloud of all the risk factors that I ran. As you can see, substance abuse and psychiatry are on the top. So most of the studies identified these two as a risk factor for OUD. However, there are others like, these two factors are also present in the clinical guidelines. But, factors like pain catastrophizing or, running into legal issues or family history may not be in the guidelines. So, are not in the guidelines. As a result, it was essential to get all I could find and kind of get a consensus on which of these play a role when the primary care providers are trying to decide risk for their patients. It's important to note that the literature on this topic and the way they define the outcomes in the studies varied a lot. So there was a use of all different kinds of outcome definitions in the studies, and most of them did use a validated screening tool to define an outcome. And even within the validated screening tool, there was a variability in what tool was used to define misuse or abuse. I just wanted to touch upon the heterogeneity about this literature to give you a sense of how complex this is. In the end, I ended up with the iterative primary care provider consultation. I ended up starting out with 57 items for my next step for the prioritization step. They span 9 different behavioral and psychosocial domains: demographics, substance use, psychiatry, socioeconomic, pain and function, medication, aberrant drug-related behaviors, medical comorbidities, and genetics, And you can see that the aberrant drug-related behavior list was huge. It was around 16 elements and items from that topic. So to give you a little bit of background about Delphi process, it's an iterative survey process where participants are given a questionnaire in multiple rounds of survey takes place with the selected group of participants. In this, the goal is to come to a consensus. In a full Delphi survey, the first round is basically a qualitative round where we collect a broad perspective on a topic in order to use that to build the quantitative part of the survey. However, for my work, I substituted the first round with the in-depth literature review and upfront primary care provider input, and essentially eliminated that qualitative round. And my first round was a quantitative round. And I also wanted to kind of understand the impact of the level of experience on rank on consensus. If the, whether a provider with more experience may identify or rank opioid use disorder differently than somebody with less experience. And for this, I defined 3 levels of experts for the survey. So here's how the survey looked. There are multiple pages of it, of course, but just to give you an idea, each OUD risk factor within each domain was ranked by primary care providers on a Likert scale of 1 to 5. Also, I did include and identify the need for a qualitative data if in case there was something I missed, or there were some additional concepts that may arise from this survey. Therefore, there was one open response question on the survey to collect any additional factors. And I did kind of made an attempt to get primary care providers from different types of primary care setting. So there were clinics at OHSU that were approached, and also clinics in the community. I also included clinics that were that qualified as a federally qualified health centers. So here is the Delphi process, and the essential elements of the Delphi process is defining the consensus upfront. I defined my consensus as more than 75% of the participants rating an OUD risk factor or concept within these 3 categories. So if the concept fell into the extremely and very useful category, and more than 75% of the participants agreed it was extremely and very useful, the consensus for that item was decided to have been met. And it's essential to note that I did collapse my 5-point Likert scale to 3-point in order to analyze my responses. The second essential part of the Delphi survey is the control feedback. So with each subsequent round, in each subsequent survey, we provide the participant with the aggregate response from the first round. In this case, I provided them with the median for each opioid use disorder risk factor, and also the individual participants' response from the first round, so that they can look at how they compare to the group opinion and have a chance to change or even stay the same, depending on how they felt about the opioid use risk factor. In the end, ranking for all opioid use disorder risk factor was determined using the mean after the final round. This is essentially a flow chart, just making a sharing that there were some of the participants that dropped after the first round, and I did make an attempt to understand if there were significant differences between the responders and the non-responders. So I did statistical tests to determine if the responders and non-responders differed, and I found that there was no significant differences, and except for the professional training category, where I did lose 2 naturopathic doctors in the second round. So that was just important to know for my own interpretation of the results. And if you remember, I did say that I wanted to see if the experience has an impact on the consensus and the ranking of the survey items. And I found that when I looked at the responses from all level of experts and compared that to just the responses from level 2 and 3 experts, the ranking did not shift a lot within 1 or 2 places. And so the consensus was also not very different. So the major results from this was, what I found was 34 OUD risk factors from the 57 that I used. 34 OUD risk concepts and factors reached consensus as very or extremely useful, 3 as moderately, and 1 as not useful. The one that was not useful was the genetic factor, and providers in the primary care setting really do not know how to use that genetic data or interpret that for the patient in front of them. A lot of things is very contextual. Most of the top ranking concepts are also mentioned in the CDC guidelines, so that was good to know. Aberrant drug-related behavior constitute about half of the very or extremely useful consensus list, followed by substance use and pain and function factors. So looking at the open-ended participant responses, I identified additional information needs and relevant concepts involving social support that are not specified in the CDC guidelines. Many of the social support constructs align with the standard social determinants of health that are increasingly being collected in the healthcare setting. Others, however, are not typically assessed or recorded, like patient-provider trust, patient activation, and patient self-efficacy. So here's a response from one of the participants that kind of provides a platform for looking at the data readiness issue. So he says that while many of the items may be useful, I wouldn't trust our EHR to reliably provide me that information and things like personality disorder can be long-lasting chart lore without any actual documentation. I also want to touch upon the limitations. We did not add new concepts from the first round. The new concepts that emerged from the open response did not use it for the second round. The structure of the, and that was done for the interest of time. The structure of the survey did not allow for exploring relative importance or ranking of OUD risk factors and concepts when presented in combination with other risk factors. Most participants were from academic health centers with strong culture for teaching and research. And so these findings may not, the findings from this effort or this study may not be generalizable. So in conclusion, there is a good alignment between CDC guidelines and primary care providers as far as the top risk factors for OUD goes. Providers consider social support factors in determining OUD risk for their patients, which came out from this process. There's an importance of the latent constructs like patient-provider trust and patient self-efficacy that needs to be explored further. While aberrant drug-related behavior seems to be most important information domain for making OUD risk decisions, these are not systematically collected in the EHR. And as a result, there's a need to determine the data readiness of top-ranked OUD concepts and factors, and think about informatics projects to address that. So here is my third question. What does accessibility and quality of highly useful OUD concept and factors look like in the EHR? And for this, it's a two-step process again. I did the operationalization of looked at the operationalization of each of the high-ranked OUD risk factor in the clinical setting. So how may they be used in the clinical setting? And then mapped them to data standards and variable. And also used a quality assessment of completion and correctness and availability to assess the quality of high-ranked OUD risk factors to determine data readiness. When I looked into literature for data readiness frameworks, this is what jumped out, one of the key papers, more recent papers, which define data readiness as in terms of quality, availability, interoperability, and provenance. However, I started thinking, what about computability? Because computability is required for learning health system, and it's important for improving care, enabling research, and informing policy. Computable data are easy to extract for secondary uses, and they're easy to retrieve for display at the point of care for calculating risk scores. So I made an attempt to define computability within these elements. So I decided definability probably is important. Structured field is important, and standard terminology tools and code or code sets are important in order for data to be computable. This is the data quality worksheet that I used. Essentially, you can see that for each OUD factor, in consultation with the primary care provider, I decided how they are documented or operationalized in the clinical setting, whether they are present in the structured field or not, where are they present, and if they are not present in the structured field, could they be structured? Could they be derived from two or other structured field? And what are the OMOP codes for them? Is there an OMOP code or code set for each of the OUD risk factor? And also looked at if there was a standard instrument to collect that OUD concept or a factor. And the reason I used OMOP codes are the OMOP common data model is a widely adopted common data model. And the vocabulary in this model is fairly robust, and it maps to a wide, multiple clinical data standards. And that was a reason for me to select and use OMOP codes to see if there were standard OMOP codes for each of my OUD risk factors. So these are this was the high-level result. Basically identified that 10 of the 34 OUD risk factors can be determined as computable. And mostly they had structured field to collect them, and they had standard OMOP codes. Potentially computable, again, as I said, that if they were collected using standard tools, and is there a way that a structured field can be generated to capture that if a standard tool was being used to collect that in the clinic. Again, can they be derived from two or more structured field? Some of them required temporality to be established, so that made them potentially computable. There was, so 14 of them were potentially computable. That was the largest group, and then 10 were non-computable. If you look at one of the, just to give you a sense, like missing medical appointment, it needs to be defined further. It needs additional patient and practice level context to define, and make it computable. So how many medical appointment a patient need to miss in order for him or her to be flagged, or how what kind of medical appointments are they missing. So that gives you an idea about what went into deciding needing further definition. So when I followed my flowchart of definability, structure, and standards, just to give you a high-level results, as a 30% were computable, as I mentioned in the prior slide, 40% potentially computable, and 30% non-computable. Now we reached the second part of my aim 3, where I did a data quality assessment of the top 10 computable OUD factors and concepts. In order to do that, I developed a search query for data extraction from the OMOP instance of the research data warehouse here at OHSU for adult patients on long-term opioid treatment for non-cancer pain between January 2018 to 2019. And the reason for that time period is the guidelines came out in 2016, and it gave enough time for some of the practices to kind of formalize in the clinic. I used the CDC guidelines, a quality improvement document by the CDC to define the cohort and use that for data extraction strategy. So that was the data extraction part of it. I also needed to do chart review, and so I decided I would do for 30 patients on long-term opioids to see how these concepts, the 10 computable concepts, appear in their chart. The data quality elements that were used were correctness and completeness, as defined by the Hogan and Wagner's method. So here's a 2x2 table. Essentially, Hogan and Wagner defined completeness and correctness using the sensitivity and positive predictive value measures. This is the result from this effort. As you see that alcohol use disorder has a fairly high, actually 100% sensitivity. So what the data that I extracted for the 30 patients, if anybody had alcohol use disorder, it did show up in the chart as well. So that was good. So let's just go over some of the major findings from this. So each highly useful OUD risk factor or concept was present in at least, not each highly, but each of the 10 computable risk factor was present in at least 10 or 20% of the patients. History of substance use disorder and showing symptoms consistent with opioid withdrawal are present in almost 40%. So that's a good, that the providers are actually documenting history of substance use disorder and realizing it's a significant risk factor, and it's happening in the clinics. Patients with current substance use disorder were more likely to have history of substance use disorder. And so synthesizing the results from this effort was even though history of substance use disorder and showing symptoms consistent with opioid withdrawal were present in almost 40% of the patients, and had one had a greater sensitivity than the other. So history of substance use disorder was more likely to be complete in both places in data that I extracted than the symptoms or withdrawal symptoms. And there's a reason for that. Providers are more likely to check and document in the problem list or a structured field data about history of substance use, as this is, as I said, is a high risk factor for developing OUD. However, providers are less likely to document signs of dependence, since most of the patients who on extended use do develop dependence on opioid use, on the prescription opioids. So the second thing that jumped out was establishing standard workflow for collecting OUD risk factor increases its sensitivity or completeness. So in the clinics at OHSU, we have a standard workflow for collecting alcohol use data, which results in a better sensitivity for this risk factor. PCP champions, primary care provider champions, and local culture affects the completeness of OUD risk data. Providers at OHSU defined hazardous situation due to opioids as fall and motor vehicle accident. And this I found while talking and consulting primary care provider here at OHSU. As a result, fall and motor vehicle accident get coded as a problem or as an encounter, hence increasing their availability and completeness. Historical problems and those with associated stigma are less likely to be captured in the structured field, like history of non-fatal overdose, suicidal ideation and attempts, history of childhood sexual abuse, physical and mental abuse. Though present in nearly 20% of the sample, 30 patients that I did the chart review on, it has zero sensitivity. So that indicates, even though there are codes for this, standard codes, and a structured field, it doesn't end up there. Patients, there is some reassurance though. The patients will not be falsely flagged for an OUD risk factor despite having high sensitivity. So high positive predictive value for the following OUD risk factors like alcohol use disorder or hazardous situation due to opioid use, history of substance use disorder, illicit drug use. They had comparatively higher sensitivity, but they also have high level of correctness or positive predictive value. So that would prevent them, and any patient who's flagged at least is clearly has that risk factor. However, there are limitations. So the reasons for low completeness could be due to in the extracted data, could be due to incomplete standard code sets to extract the data. And there may be issues arising due to temporality. Finding may not be generalizable, but I do emphasize the methodology is. So even though this finding may not be reflected in some other healthcare center, this methodology can be adopted to understand information needs and information readiness gaps. Using the manual chart review as a gold standard was also a limitation because we know that there is care fragmentation and limited operability, and that can result in what we see in the chart. So in conclusion, it is essential that risk factors and concepts from OUD are findable and computable to meet the triple aim of quality care, research, and policies. This work is a novel attempt to incorporate provider knowledge and experience from the real-world practice of OUD risk assessment. It provides a framework for defining the gaps between information needs and readiness for complex conditions with considerable stigma. This is a generalizable methodology to prioritize informatics efforts for standard and computable data to enable learning health system and evidence-based care, which is not currently available. The work extends the current data readiness framework to include computability as a construct. So the future work for this that results from this effort is we can help prioritize future informatics projects to get more or better data, especially improve completeness for computable and potentially computable data by destigmatizing the problem, establishing standard workflow, identifying provider champions, and improving standard code sets. And also for non-computable data, there is a role that NLP may play in retrieving that data to the point of care. So I just wanted to close the loop on where I started and how I ended. My original research question was, why is there a gap between guidelines and practice? And I found that part of this gap is due to the insufficient documentation. So then I asked in my aim 2 if the problem is that the provider agrees with the guidelines in determining OUD, if the provider agree with the guidelines in determining OUD risk. And I found that for the most part they do, though I did identify some additional psychosocial factors that may play a role in the OUD decision making. So then, knowing that provider agrees with guidelines on high priority concepts, I asked if the data available for those concepts are sufficient for the task. And I found that often they are not. Either they are not computable or they are computable but incomplete. So there is, in spite of all this, this isn't a problem about documentation or needing to balance increased documentation and provider burden. This is a clinical space with a great deal of stigma, where patient-provider trust is extremely important. This is a key consideration in documentation practices and not one that is present in many common medical conditions. Methods to address documentation insufficiency and improve risk prediction, data availability at the point of care, and other use of data must be informed by these challenges. And so I leave you with this final thought on my work. I acknowledge my DAC committee member, my research advisor for her great help and believing in me, Dr. Mary Pickett, Dr. Dana Wallbach, and Dr. Stephen Pedrick. My mentors, Karen Eden, Jonathan Robbins, Ben Sanders, Chris Hoekstra, Vishnu Mohan, Ben Hirsch, Aaron Cohen, Joan Ash, and Steve Kasakian. They've all shaped my work. DMICE student and staff who've helped me tremendously, and special thanks to Brian Chan, the addiction medicine staff, fellows and faculty who gave me an opportunity to sit in their didactic conferences, the clinical directors here at OHSU, in the internal medicine, family medicine, and Centers for Women's Health, who helped me during the survey process, and the National Library of Medicine, of course, for this award. And wanted to also, thank my parents for nurturing the spirituality and curiosity in me to take this journey and complete it, and my family for their tremendous support. Thank you so much. Oh, I have to see.
Yeah, why don't you on the slides,
Oh, okay.
questions? Or just unshare your screen. See them.
Chat. Let me see.
So maybe I'll ask a question.
Yeah.
Thank you. That great talk. I sense in your conclusions a little, not the right word. I'll just say ambivalence. That's probably not the right word. But so it's like on the one hand, there are possible solutions to the data elements not being computable that will help drive decision support, practice improvement. On the other hand, you found that the clinicians take issue with the guidelines, so that you may come up with a really good solution, but, will the clinicians accept it? So I guess my question is, if you were going to pursue this work further, what would be your path, and how would you reconcile those potentially conflicting areas?
Yeah, and thank you for bringing to light the complexity about the issue, and it makes even more sense for including the provider community when we are building an informatics solution for this problem. Any informatics solution needs to be informed what the real expectation or real how is going to be intended to be used in the clinical care setting, and whether provider consider that it may cause some harm to the patient or not. So helping, making sure that interventions do not cause harm to the patients, especially due to the stigma around some of the stigma being a huge issue. It's very essential that provider community and to some extent patient community be considered when we are developing a informatics solution for data availability for making real life decisions. Yeah.
Thank you, Meena, for that excellent presentation. I have a question, and maybe I missed it in your slide about when you were talking about the availability of data. Was there a relationship between the computability of an element and its frequency in the EHR? Like, were computable items more likely to be present, or was it more the qualitative items that people were documenting what's frequently?
So that's a good question. We do. So I think all of us are aware of the copy and paste that happens. So once a thing is captured in the narrated notes, there's a likelihood of it being present in the narrated note with a greater frequency. The computable items were, as I said, they had a high degree of positive predictive value. So they, they were, once they are captured in the structured node, you would find them consistently still. So it all depends, what, how often those computable documents were captured for them to be appearing frequently, if I understand your question.
The process effects.
Exactly. I'm not seeing any questions in the chat.
Okay, well, we can leave you to your committee. They may have some further questions. So thank you everyone for attending, and nice job.
Yeah, I also wanted to point out that today is the Overdose Awareness Day. So just wanted to draw attention of people attending this event. Thank you.
And I'll hang around here on the Zoom.
All right, Meena. We'll need to stop recording.
Thank you.